Well, good morning to everybody, and welcome to today's Medical Grand Rounds. As a reminder, our speaker next week will be Dr. Paul Cieslak from the Oregon Health Authority, who will be giving the talk, State of the State in Infectious Disease. And just a few reminders and logistics. We are, of course, here on the Teams Live platform. This is currently a virtual viewership and shared program between Providence St. Vincent and Providence Portland. You can earn CME credit for being with us here live virtual or also by watching a recording of the session. And the link to that video is the same as the invite for today's Grand Rounds. Please do stay tuned as we continue to reassess the opportunity for limited live and full live viewership. And in fact, Dr. Cieslak will be live in Souther Auditorium next week. So please check in if you'd like to come in person. I'll be monitoring the Q&A throughout the session today, and I'll mostly hold questions for the end as time permits. So go ahead and post your comments or questions for today's speaker. And now to introduce him, our good friend, Dr. Lenny Menken is here. He is a practicing internist and associate program director for the internal medicine residency at Legacy. Dr. Menken, originally from Los Angeles, earned his medical degree at Dartmouth in New Hampshire, then returned to California to do internal medicine residency at UCLA, where he also served as chief resident and went on to associate professor of medicine. Since coming to Portland, Dr. Menken has mostly practiced internal medicine in the outpatient setting. He previously taught at OHSU and still teaches students from there, and has been an associate program director at Legacy since 2007. His academic interests include many, including hypertension, hyperlipidemia, and diabetes management. He truly is a renowned teacher and is extremely generous with his time presenting here on the local and regional level and right on up to the national level, and will be presenting at National ACP later this spring. Dr. Menken, many of you know, is a trivia guru. He competes locally and has been kind in hosting the Oregon chapter of ACP Trivia Night at our meeting every year, several years running. So Dr. Menken, always fun. Thank you for joining us again today.
Well, thank you so much, Laura, for the invitation. It's always great to be amongst you folks. And hopefully I can pass on something that I've learned over the last year in regards to outpatient medicine. And so without further ado, they asked for disclosures. And so, all right, glad I got that off my chest. Stephen, enter in the chat if you're out there. All right, objectives today. I want to review recent literature on relevant IM topics. And I'll use cases to present some ideas. I'm going to avoid any mention of COVID-19. I'm going to try and keep you guys awake, and I'm going to try to avoid information overload. I don't want to flood you. All right, so our schedule today, we've got not too bad a clinic day. We're going to see a new patient for gyne screening. We're going to follow up a patient who was HPV positive on a screen. We've got a physical. We've got somebody coming in with palpitations, new heart failure, and some hypertension, diabetes. We'll find out what all this is about. So our first patient is a 21-year-old woman who presents to the clinic for her first gyne exam. She says she's sexually active for the last couple of years, uses barrier protection along with OCPs. She's currently asymptomatic. She has not received her HPV vaccination due to her parents' hesitancy. And so talking briefly, reviewing cervical cancer. So cervical cancer affects almost 15,000 women every year in the United States. And there are approximately 4,000 deaths every year from cervical cancer. Cervical cancer disproportionately affects the world women's health in the sense that it's the #4 cause of death overall for women across the globe. and that primarily occurs in low and middle income countries where they don't have adequate screening. Almost 100% of cervical cancer comes about from a prior infection from HPV strains. In the United States, most cancer occurs in women who have not had the opportunity or have not taken the opportunity to undergo screening, or who do not follow up on abnormal results. And unfortunately, this disproportionately affects immigrants, people of color, and people of low income. So cervical cancer is very interesting. It was the #1 cause of cancer death amongst women in the United States in the mid-1900s up until the 1950s, when screening programs were instituted under the leadership of Dr. George Papanicolaou, who really made a difference in this world. And so how do we honor Dr. Papanicolaou, one of the most prestigious scientists of the last century? Well, of course, we name a very uncomfortable test after him. And then his native country, Greece, honored him with the now defunct 10,000 drachma note. And of course, in the United States, we remember him well with the 13-cent US stamp. All right, he definitely deserves better. So here's cervical cancer over the years. So this is since 1975. You can see a slow, steady decline in the number of cases of cervical cancer and also the death rates of cervical cancer. And recall that in 2006, we instituted an HPV vaccination program, and hopefully we will see some effects of that come right about now. About 15 years or so out from vaccination is where we expect to start seeing trends decreasing, hopefully, in cervical cancer incidence and mortality. Cervical cancer is the ideal cancer for screening because it has a really long lead time. And so patients spend a long time in a localized phase before the cancer then spreads regionally and far away. And if you can catch it localized, you have a really high chance of cure. All right, so hopefully that was all pretty much review for you guys. And so now, anything new in the world of cervical cancer prevention? So in July of 2020, the American Cancer Society updated their screening guidelines for cervical cancer. There was a lot going on in the world at that time, and I think these kind of went under the radar for a lot of folks. So let's review current guidelines. So the 2018 USPSTF guidelines is what most of us have been following. So between ages 21 and 29, you do a pap smear every 3 years. Between 30 and 65, they recommend either HPV alone, so primary HPV testing every 5 years, or a combination HPV and pap every 5 years, or you could do the pap cytology every 3 years. And then at around 65, if you've had a couple of negative tests in the last 10 years, they recommend no further screening. So what about this 2020 ACS guideline? How does it differ? Well, the first big difference is they don't recommend screening women in the 21 to 24 age range. So they want screening to start at age 25. And then they say from age 25 to 65, they want us to do primary HPV testing alone every 5 years, with options for pap or co-testing if for some reason primary HPV is not available, and then ending at the same age of about 65. So a little bit of a departure from our standard screening. So let's talk about why they've made these choices. So why start at age 25? So although rates of HPV infection are quite high in young women, most of those infections self-resolve, as do the histologic changes that occur in the cervix during that time. Overall, less than 1% of cervical cancers arise before age 25, and it's not believed that doing our screening actually will prevent these cancers or cancer deaths from that. But it certainly increases the screening burden, the discomfort, the false positives that occur during that time, overtreatment, which can lead to obstetric complications, and then of course anxiety and costs that go along with these procedures. So why did they choose HPV over cytology? So primary HPV testing every 5 years turns out to be more sensitive for dysplasia, and it has a better long-term negative predictive value. So you can actually get a negative HPV test and rest assured that you can go 5 years between your screening exams. And then as we've been vaccinating people, there are more non-important HPV strains that are infecting women's cervixes. And so those strains do not increase the cancer risk and only increase our chances of having false positive cytology results. So the recommendation is HPV alone. So HPV testing is good. Wouldn't it be better to do both together? So it turns out that primary HPV testing has nearly equivalent sensitivity to the combined testing, but has improved specificity over that combined testing. So you're going to get less false positives. And a single test is more cost effective than doing the dual. So if primary HPV testing is superior, then why did the ACS even mention the options for PAP and co-testing? And the reason for that was a practical one. There are only 2 primary HPV tests out there on the market. The primary HPV test is actually different from the test that they use when you do a reflex HPV test. So these primary HPV tests are only available in about 40% of laboratories in the United States currently, and mainly in major city centers. And so the ACS said once primary HPV testing is available universally across the country, they're going to get rid of any recommendations for using cytology for any reason. Here's an estimate of benefits and risks between the 2 types of screening programs. So the top one being the new ACS model, and the middle one representing the recommendations. And so for the ACS, you see that there are equivalent numbers of cancer deaths as compared to the what we've been doing traditionally, and obviously a huge decrease compared to no screening whatsoever. But what we do is we cut down the number of lifetime pelvic exams without significantly increasing the number of lifetime colposcopies. Can we further reduce our reliance on the pelvic exam for cervical cancer screening? So obviously not something that women look forward to. Is there a way to further cut down on the numbers of these examinations? And so along comes the idea of self-screening for HPV. So for women who lack access to healthcare or who are unwilling to undergo a pelvic exam, they can self-swab for HPV using different techniques. And this may offer an alternative method to pelvic exams and physician-collected samples. Are these self-screens accurate? So it looks like they're incredibly accurate. So this was a meta-analysis of 25 trials showing excellent accuracy for advanced cervical dysplasia using HPV PCR from vaginal self-collected samples. And so women are able to basically do this test on their own. I envision a day where, similar to people doing FIT testing for colon cancer, we will send women home potentially with a self-swab that they send into the lab. So clinical bottom line for screening, HPV testing alone is more effective than cytology and more efficient than co-testing. Initiating cervical cancer screening starting at age 25 with HPV testing every 5 years until age 65 appears to be a reasonable approach for cervical cancer screening. And HPV self-screening may be a viable option, especially in the underscreened populations that I mentioned earlier in the talk, the disenfranchised within our society would have a lot better opportunities to get screened and reduce their rates of cervical cancer. So her parents didn't allow her to get her HPV vaccinations. She's now 21. Should we recommend that she get them at her age? So HPV vaccination targets a lot of the high-risk HPV strains out there responsible for roughly 90% of cervical cancers. It was first recommended officially in 2006 for ages 9 to 26, and we now recommend it up to age 45 in both women and men. HPV vaccination, of course, reduces HPV infections. It also reduces genital warts and high-grade cervical lesions, the CIN2s and 3s of the world. How are we doing at this point at getting young women vaccinated in the United States? So we're doing meh. About half of the teens in the United States and half of girls up to age 24, or women up to age 24, are up to date or fully vaccinated for HPV. So we're not quite there, but making headway. A super important question is, does HPV vaccination actually prevent what it's intended for, invasive cervical cancer? So it's somewhat difficult to assess from the randomized trial data from the initial groups because there's a long lead time before cancers actually develop. But we do have some data from the initial group. We've got 27,000 women from early randomized trials. They were followed for 7 years total. And in the group who received vaccinations, none of them developed an HPV-related cancer, as compared to 10 women in the placebo arm. So encouraging data, but obviously not enough to really hang our hats on. What I thought was a lot more interesting was this study out of Sweden, in which they looked at almost 1.7 million girls and women who were followed from 2006 to 2017 getting HPV vaccination, and they compared them to groups not getting vaccinated. And here's what they found, that for unvaccinated, there was a significantly higher incidence of cervical cancer versus the vaccinated group. Only 19 women out of 500,000 developed invasive cervical cancer. And looking at that 19, it's interesting that if those women were vaccinated before age 17, that only accounted for 2 cancers. So 2 cervical cancers out of 440,000 women, and then the rest, although they had lower rates, they overall had a higher chance of getting cervical cancer if they received their vaccines after age 17. So clinical bottom line here, this woman should receive her vaccination. HPV vaccinations appear to be an effective means for reducing the burden of cervical cancer, and especially if you can get them young, especially if you can get them before they've been introduced to the HPV virus. So if trends continue like this, future screening protocols should reflect whether or not women have received the vaccination. So I think this is what's coming down the pike, and there are a lot of models out there, one from Norway, in which they suggest that we may be down to just 2 HPV screens in a lifetime if someone has been vaccinated. So we're going to see, I think, huge changes. And it also makes me wonder, what will women go to the doctor for? I say that sort of, half-heartedly as a joke, but truly that's what brings young women into healthcare, and this may actually change what healthcare looks like quite a lot if they no longer need to come in so regularly for screening at young ages. All right. Our next patient is a 32-year-old woman who comes in after her HPV test turned positive on her routine screening. So what do you do when women have a positive HPV test? Well, traditionally, we need to figure out if they have a high-risk lesion, which would require colposcopy, a definitive treatment, versus a low-risk kind of lesion that can return to normal or routine screening. And what we normally do is we obtain a pap smear at that point and see what things look like. Anything new in this world? And I just wanted to mention to you a new test that's out. This is called dual stain testing. Dual stain testing employs molecular markers, these 2 specific ones that are found in cancer-causing strains of HPV, and they're highly predictive of cancer formation. And so in a study looking at women who tested HPV, high-risk HPV positive, 1,500 of them, use of dual stain was superior to PAP, to cytology, in predicting development of CIN2 lesions or greater over a 5-year period. A separate study used dual stain plus artificial intelligence, where the computers were actually reading the slides rather than humans. And they found in a study of 4,200 women who were HPV positive that use of this artificial intelligence dual stain resulted in improved specificity for detection of cervical precancers, the CIN2s and 3s, and overall referral for colposcopy was appropriately reduced by about 1/3 using the dual stain test. Here's what a dual stain test might look like, and the computer has been trained to recognize these cells in the center as being abnormal, and it will flag that particular slide. So clinical bottom line, this is just a quick hit case. Dual stain testing, be on the lookout for that for women who are HPV positive as a more accurate means than cytology for determining if a woman needs to go on to a procedure. And AI technology may further improve the accuracy of this dual stain testing. And just want to do one more shout out to Dr. George Papanicolaou. We may be seeing the end of the era of the pap smear, but he certainly will not be forgotten. Our next patient is a 46-year-old healthy woman who prevents for follow-up. She's up to date on her cervical cancer screening. Oh, thank goodness. Don't want to talk about that anymore. And she's opted to start mammography at age 50, so she's not quite ready yet. Any other screening tests that you would suggest? And so this is just a reminder that there have been a couple updates. Hepatitis C is one. Hepatitis C is currently the most common blood-borne pathogen. It affects about 1% of the US population. There's about 45,000 new cases diagnosed every year, and this number has been increasing at an alarming rate, about 4-fold increase since 2010. It accounts for more death, hepatitis C, than the top 60 other reportable infectious diseases, including HIV. Updated their recommendations in 2020, recommending that we now screen all adults ages 18 to 79 years with an anti-Hep C virus antibody. And then they recommend repeat screening in anyone who's at a particularly high risk, mainly people who inject drugs, although they don't recommend how often we test those folks. Screening ages 18 to 79 will apparently result in identification of about 250,000 new cases of hepatitis C that are currently unrecognized, and will hopefully prevent over 4,000 cases of hepatocellular cancer. The other cancer that I think you guys are probably well aware of is colorectal cancer. We've had some changes there as well. CRC is the third most commonly diagnosed cancer, the second leading cause of cancer death in the United States for women and men combined. And estimated totals, 104,000 cancers are diagnosed each year in the United States, including 45,000 rectal cancers, or not including, but and there are 45,000 new rectal cancers, with a total of about a third of those, a third of that number dying from colorectal cancers. The trends have shown overall declining rates since the 1980s, since we instituted screening programs. And most of those declines in the past decade have involved older cohorts of patients. However, from 2012 to 2016, colorectal cancer increased by 2% per year in people under age 50, and by 1% per year in the 50 to 64 category. And so the need to do something a little bit more has surfaced. And so the USPSTF now recommends that we traditionally screen people aged 50 to 75, but also with a grade B recommendation, start screening people in the 45 to 49 year age group. And then consideration of colorectal screening should still be given for adults aged 76 to 85 if they're otherwise in pretty good health. So clinical bottom lines here, these are just really quick reminders that like HIV, there's now a recommendation out there to screen all adults for hepatitis C, not just the baby boomers, and CRC screening may be initiated starting at age 45. All right, moving on to our next patient. I think we're keeping on time. We've got a 55-year-old man who comes in for some intermittent palpitations. He received a notification from his Apple Watch, which he probably got on his birthday. And the Apple Watch said, hey, something appears to be wrong with your heart rhythm. Great, people coming into the doctor now because their smart devices are telling them to. Is this something we should be taking seriously? So let's talk about this. The Apple Watch makers instituted a very large study. And so Apple Watch wearers were monitored using their watches with their permission for irregular pulse. Participants were then notified of an irregular heartbeat, and they were sent an EKG monitoring patch to be worn for up to a week. And then they wanted to know what proportion of these notified participants actually were confirmed to have AFib on an EKG over the course of a week. The data was collected via Apple, and then it was immediately turned over to researchers at Stanford. So the Apple folks did not have anything to do with the actual data analysis. And how did this all shake out? So they actually looked at 430,000 Apple Watch wearers who did not have AFib at baseline. They monitored them for about 4 months total. Of those folks, 2,100 or so were notified of having an irregular rhythm, and they were sent what's called an EKG patch, where their watch will now observe for abnormal rhythms and when those occur, it will generate an EKG. Of those 2,100, 450 took their EKG patch and used it and returned their data. The 450 people with EKG data showed that AFib was documented in 119 of them, meaning a 34% sensitivity. Frequent PACs, PVCs, atrial tachycardia, and non-sustained VTach were diagnosed in 40%. The fact that AFib was diagnosed in 34% doesn't mean that the other 66% didn't have a run of AFib initially. It meant that over the course of their EKG monitoring, it didn't show up. But remember that AFib is oftentimes paroxysmal, so those numbers could actually be higher. So there's some newer versions now of the Apple Watch that now include an automatic EKG. The patch that was used in the initial study is now just an automatic for Apple Watches, I believe level 6 and above. And it, according to the manufacturer, is able to detect AFib with a 98% sensitivity and close to 100% specificity. There's now Apple Watch Series 6 and above that are also offering oxygen saturation monitoring using the same plethysmography technique. And so while it's not approved for medical use yet, this is something that potentially could be coming down the pike. So I was thinking about these Apple Watches and how they might change what we do. And so here are the things that just off the top of my head I was thinking about. For potential applications, we talk about cryptogenic stroke and the study that showed that a lot of people who have stroke or TIAs actually have underlying AFib if you monitor them for long enough. And so could we use Apple Watches for that purpose? People who undergo cardiac procedures, we oftentimes monitor them for extensive periods after the procedure, and we'd love to know what things look like when they go home. These Apple Watches would be an ideal kind of thing for discharge. Workup of palpitations and syncope. We no longer have to wonder about using these event monitors, etc., which can be costly. Exercise monitoring, we can have more extensive cardiac rehab classes where people are wearing their Apple Watches to monitor their heart and how they're doing. We could use this for drug monitoring, for QT intervals, especially on patients who are on multiple QT altering medications. And then this may come down to screening. So should we screen the older population for atrial fibrillation, especially high-risk folks? So those are all just off the top of my head, things where I can see these really coming to play probably in the next 5 to 10 years. And these Apple Watches, are becoming less and less expensive. And I think cheaper versions will also be available through other, competitors to, these things might eventually be in the Happy Meals that our kids are getting. Hopefully you're not feeding your kids Happy Meals, but you get my point that this technology is becoming less and less expensive and more accessible to the general population. All right, so my clinical bottom line here, smart devices are capable of identifying unrecognized atrial fibrillation, as well as potentially other important arrhythmias. Stay tuned. This is one of my favorite camping trips with my daughter. This was during the early stages of COVID where they shut down all the forests, and we went anyway, and we had this beautiful Lake Olali all to ourselves. All right, this is our next patient, patient 5, 72-year-old woman who comes in for follow-up after hospitalization for acute onset heart failure. She was diuresed and sent home on PO furosemide. Her echo revealed an EF of 60 to 70%, so she has HFpEF, heart failure with preserved ejection fraction, accounts for roughly half of folks who get hospitalized for heart failure. And overall, we've seen no reduction in heart failure hospitalization or mortality in patients with HFpEF using traditional agents that we usually use for patients with HFrEF, such as ACE inhibitors, ARBs, beta blockers, spironolactone, the sacubitril, valsartan, combinations, etc. And so what about HFpEF? Is there anything new in this world? So let's talk about a diabetes medicine. So this is probably very familiar to you guys. The SGLT2 inhibitors are the newest class of medications being used for diabetes and also now used for heart failure. So the SGLT2 inhibitors are the ones that block your glucose reabsorption in your proximal tubule of your kidney. And so you pee out the glucose, water follows. It has diuretic effects. It lowers blood pressure. It lowers sugar. And it's been shown to be helpful at reducing heart failure events in patients with diabetes with or without baseline heart failure. So it appears to reduce heart failure in all diabetes patients. And it improves heart failure now in patients with HFrEF, the reduced EF heart failure. So these appear to be pretty miraculous medicines. They're really helping a lot of folks. Do these medicines help people with heart failure and preserved ejection fraction? And so this study came out last year in New England Journal. It was called the Emperor Preserved Trial. They looked at 6,000 patients with HFpEF. All of them had an EF greater than 40%. 2/3 of the folks had an EF greater than 50%, with an average EF of 54%. These folks were randomized to receive empagliflozin, 10 milligrams daily, or placebo. They were followed for 2 years to look at the outcomes of heart failure hospitalization or cardiovascular death, or the combined outcome. Average age of the folks was 74, and let's see what happened. So as you can see here, the primary outcome, combined heart failure hospitalization or cardiovascular mortality, was significantly reduced in the empagliflozin group with very significant p-value. Most of the difference was seen in the CHF hospitalizations with quite a reduction in number of heart failure hospitalizations. There was a trend towards decreased cardiovascular mortality, but that was not significant. Empagliflozin is an expensive drug at this time, so that's one of the main downsides. There are other side effects to the medication, but I think this is the biggest one that's preventing our general use. What I wonder is how much would it cost to prevent one primary event in the study, a single heart failure event over a 1-year period, and that cost is roughly $1 million to prevent a single heart failure event. So I think that kind of brings it to light just how expensive it would be to try and institute this widely amongst people with HFpEF. I also think about it in slightly different terms. So empagliflozin costs $588 per month, and I wonder if you offer to patients some alternative, say an Alfa Romeo Giulia, a very nice car. They could lease that over a 36-month period for a brand new car for just less than it would cost to take the empagliflozin. Or as an alternative, if you're a traveler, you could get a beachfront villa in the Canary Islands. You'd have to pay $511 per month over the course of just 1 year to get a rental for 4 people in the Mediterranean. Of course, that does not include airfare or food. Let's not get greedy. All right, so to review those choices, you can go on empagliflozin, you could get an Alfa Romeo, very nice looking car, or you could be holed up here in June with 3 of your closest friends for an entire month. Okay, so empagliflozin is the first drug to lower risk of heart failure hospitalizations in patients with HFpEF. I'm excited that we have a treatment that's helpful for these patients, and I'm also hopeful that these drugs will become more affordable with time. All right, we're on to patient 6. We have a 54-year-old man with history of obesity, hypertension, and elevated A1C. He comes in for standard follow-up. His BP is 148/88. His A1C is 6.0%. And you've tried everything. You've given him all kinds of advice on diet, exercise, and weight loss, and yet his numbers continue to climb. And he asks, well, what can I do to lose weight? What works? So if you look at this patient, he's classified as having pre-diabetes, if we're still using that term. He's got elevated A1C. The American Diabetes Association recommends that to prevent him going on to diabetes, that he undergo 150 minutes of exercise per week in order to achieve a 7% reduction in body weight using combination of exercise and diet. The DPP study showed that intensive lifestyle changes like that resulted in a 58% reduction in development of diabetes over a 3-year period, which was superior to metformin. So yeah, all good things, diet and exercise, we tell that to all our patients. Anything new out there for weight loss? Anything we should really have our eye on? So let's talk about another diabetes agent that I am falling in love with. These are the glucagon-like peptide 1 agonists listed here. They lower A1C by about a point. They have been shown to decrease cardiovascular events in patients with diabetes and ASCVD, so cardiovascular disease, so secondary prevention. And they have been shown to decrease progression of kidney disease in folks with diabetes. So all great things from these GLP-1 agonists. What about the GLP-1 agonists and weight loss? So in the early, so looking at these agents, they appear to have good reason to help people lose weight. They slow gastric emptying and create a sense of early satiety when eating meals. And they have a direct effect on the brain, limiting our appetite. In the early studies of patients of these GLP-1 agonists in diabetes, use of liraglutide resulted in a net 4.2 kilogram weight loss as compared to placebo over the course of a year. And when they looked at semaglutide in diabetes, they found a 6.2 net loss compared to placebo with these agents. What about using these agents in people who don't even have diabetes? Does that help? So here was an initial study of this proof of concept in New England in 2015, using liraglutide in 3,700 obese adults who did not have diabetes. They got daily injections of liraglutide and were compared to patients with placebo. At baseline, they weighed about 100 kilos, and their A1C was borderline at 5.6. These folks were followed for a year, looking at changes in body weight and figuring out if people lost greater than 5% or greater than 10% overall body weight. And what did they see? Well, they saw a significant reduction in weight using liraglutide, 18 pounds over the course of a year, which was 8% overall body weight change in this population. Roughly 2/3 of these folks achieved a greater than 5% weight loss, and a third lost greater than 10% of their body weight. Their blood pressures came down, And their A1C, remember these were non-diabetics, their A1Cs did not change significantly overall. I mean, it was a difference, but it was not an important difference. There were no cases of hypoglycemia going on in patients on the liraglutide. Were there adverse effects? Oh yeah, there were a lot of adverse effects. 4 times the number of patients had vomiting, lots of patients complained of nausea, diarrhea, constipation, dyspepsia. So a lot of events. However, only 6% of the group actually stopped their medication due to one of these adverse events. So I think people realized, hey, I'm losing weight on this product. Yeah, maybe I feel a little queasy, but I'm going to keep going. Here's a separate study published last year in New England. This looked at 195 obese patients without diabetes once again. They were placed on low-calorie diet for the first 8 weeks. You can see there that they lost 14 kilograms of weight on this very drastic diet. And then the question was, can people keep off this weight if we employ exercise or semaglutide or exercise plus semaglutide? And what they found was that liraglutide. What they found was the exercise plus liraglutide group continued to drop their weight and were able to maintain very well over the course of a 1-year study. So these people lost a tremendous amount of weight and were able to keep that off with a combination of exercise and liraglutide itself was quite impressive alone. So here's another study. This was a very interesting one last year that came out in New England. About 2,000 obese non-diabetic patients, once again, were randomized to weekly semaglutide, so that's nicer, plus lifestyle counseling, and they compared them to counseling alone. They again weighed about 100 kilos at baseline. Their A1C was borderline elevated. They followed these people for just over a year with the same kind of endpoints of percent change in body weight and did they lose greater than 5% body weight. So what happened in these people who were using weekly injections with semaglutide? How much weight did they lose? Did they lose none at all? They actually gained weight in this study, or did they lose as much as 15 kilos? So I'm very happy to report that these people lost 15 kilograms of weight over the course of a year, which represented about a 15% drop overall in their body weight. 86% met the goal of greater than 5% weight loss, and over 2/3 of people had greater than 10% weight loss, which is enormous. Their blood pressures came down impressively, and their A1Cs dropped into the normal range. Wow, this gets my vote for study of the year. Were there adverse events? Yes, very similar to what we saw in the liraglutide study. Lots of people getting nausea and vomiting, some diarrhea and constipation. And once again, only 1 out of about 13 people said, okay, I can't take it, I'm not using this medicine. Everyone else said, bring it on, I'll keep going. On June 4th of last year, the FDA approved use of injectable semaglutide for chronic weight management based on this study in adults with obesity or in overweight adults, BMIs greater than 27 with at least one weight-related comorbidity. What about in adolescents? Any evidence there? So I wanted to point out this study where they took liraglutide in 251 adolescents, once again, overweight obese adolescents without diabetes. They assigned them to daily injections with liraglutide. Their baseline weight was again 100 kilos. They studied these people over a year, and they were all provided lifestyle measures. And these people, these young individuals, lost about just over 2 kilos of weight compared to placebo, where they gained just over 2 kilos of weight. About a quarter of them lost greater than 10% of their body weight. There were again increased GI adverse events. About 2/3 of these adolescents complained of the various GI troubles that we talked about earlier, but only 1 in 10 of them said, I'm not going to use these weekly injection or daily injections, for weight loss, which is astounding to me. I can't get my teenager to take out the trash once a week, and here are these adolescents being injected daily and being subjected to all these GI side effects, and they're sticking with it. So kudos to them. All right. In 2019, the FDA approved oral semaglutide, the first oral agent within the GLP-1 class. Does the oral one help with weight loss? So here's a study of oral semaglutide in 3,100 diabetic patients. They compared them to placebo. They followed these folks for 16 months. One of their secondary outcomes was weight change. And patients on semaglutide lost an average of, oral semaglutide lost an average of 4 kilograms of weight as compared to 0.8 kilos with placebo. All right, as discussed earlier, there's always downsides aside from just the adverse events in these studies. And the main downsides are the cost of these medications. Holy cow, these are expensive drugs. I looked at it in terms of how much price is it per pound of weight loss, and you can see there it ain't cheap. However, the once weekly semaglutide subcutaneous was $433 per pound of weight loss. Doing the math, I would probably sign up for a little bit of this medication. All right. Lastly, I want to end with a question: any new devices for weight loss? Anything out there? And so I found a very interesting FDA cleared product called Plenity, or Gelesis 100. This is a novel oral super absorbent hydrogel. It's a mixture of cellulose, citric acid. It forms this network, and you take it within a capsule form. The capsule gets into your stomach, breaks open, and then it absorbs 100 times. These particles absorb 100 times their weight in water, and it occupies volume and induces satiety. It forms a semi-solid gel that occupies roughly a quarter of the volume of one's stomach. You take it about 20 minutes before each meal, and the water, once the meal passes through into the intestines, esterases within the intestines will break down the polymer. The water then gets absorbed or reabsorbed into the colon, and the remaining small amount of hydrogel is then expelled in the feces. So this is called Plenity. It was FDA cleared in April of 2019 as a device for people with BMI greater than 25. Why was it called a device? It was called a device because it never actually gets absorbed into your body, so it's not considered to be a drug. Here's what this super absorbent gel looks like in vitro. When simulated gastric fluid is added to it, it just forms this huge gel that will occupy your stomach. Any studies? Well, there was a study published in Obesity called the GLOW study. They looked at 436 subjects aged 22 to 65 and BMI greater than 27 to 40. And they compared Plenity to placebo, and they looked at the same outcomes we've been looking at thus far. They followed these people for 24 weeks, about 6 months, and they found that people on Plenity lost significant weight compared to placebo, which did pretty well too. About 60% of people lost greater than 5% of their body weight, and a quarter of folks lost 10% of their body weight. There were some GI adverse events, but overall they were pretty minimal. and withdrawal was the same as that with placebo. Here was an extension study of the GLOW trial looking at weight loss and then maintenance for another 6 months out to 1 year. And they found that people were able to lose weight and then maintain it if they stayed on the Plenity. Costs of Plenity are quite reasonable, I think, compared to a lot of the drugs we've been talking about. The product costs $98 per month, which represents about just under $2 per meal. You have to do an online program, and it may be covered by insurance according to the company website. All right, my clinical bottom lines here. GLP-1 agonists are effective agents for weight loss in patients over age 12 with or without diabetes for up to 1 year. Plenity is a new device for weight loss and appears to be safe and effective in a single randomized trial of short duration. We need some more studies. Obesity is a chronic disease. We don't treat hypertension for a year and then quit. And I think we should be thinking the same about obesity with all its comorbidities. And then finally, the question I ask you is, what did I hand out this past Halloween to kids to help combat childhood obesity? And my answer to that. All right. So thanks for your kind attention. We've got a few minutes for questions, and hopefully something came across that will help you in your practice.
Great. Many thanks, Dr. Menken, for an excellent presentation, and perhaps just dovetailing on one of those last points. I have a question here from the audience. Do we have a sense with GLP-1 agonists, if discontinued after a year, does the weight return?
We don't know that yet. I haven't seen any studies looking at the after effects once we stop the medication. Again, you know, this is one of those questions of, do we treat obesity as a chronic disease? That's my overall bent, is we probably should, especially if these medications become affordable. It seems like it only would help these folks. The side effects tend to decrease over time. And, you know, that's one of those things that we have yet to see. So stay tuned.
Thank you. And I'll back us up a little bit to the section on the Apple devices. Do we know the stroke risk and thus the risk-benefit ratio for anticoagulation for patients found to have paroxysmal AF on the Apple Watch? So any data about prevention of clinically important outcomes, I believe, is the question.
I think that's a great question. So does picking up AFib really help us out if it's in a 40-year-old healthy person? It probably doesn't help a whole lot. The recommendations still are to monitor those folks, to not use any kind of antiplatelets or other blood thinning agents. However, in people with high enough risks, just like anyone else that we'd risk stratify with a CHADS risk score, potentially they could gain benefit. There haven't been studies looking specifically at the folks detected with their Apple Watch as to whether or not they gain benefit. They did break it down. I'm trying to remember. I think it was the, I don't want to say the wrong numbers, but they broke it down by age according to how many people were detected with AFib. I think it was, I remember roughly it was about a quarter of patients were over age 65, because not that many older patients wear Apple Watches at this point, I think. So yeah, that's a good question. I think it's important information to know, and I see no difference, you know, at least in folks who have had some kind of event. It would be really important to know.
Great, thanks. We can get the data and interpret perhaps an opportunity for shared decision making.
Absolutely.
We're nearly at the top of the hour, but I'll sneak in one more perhaps quick question. Are you aware whether most insurances are covering the cost of colorectal cancer screening beginning at age 45?
So my understanding, and I'm not great with all this insurance stuff, but I believe that once the USPSTF gives a grade B or higher, then insurance companies are required to cover that service and they're given 1 year from the time of the official recommendation in order to figure that out and then start providing coverage. So in theory, if all goes well and appropriate with the law, the insurance company should be covering our patients age 45 and above.
Great, thanks so much. That has been my experience as well. I want to respect that we are at 9 o'clock and have learned much, so many thanks, Dr. Menken.
You're very welcome. I hope I helped in some small way.
Absolutely.
And
take care, everybody.
Any comments or questions, please shoot me an email. That would be great.
Perfect. We'll see you next week. Thanks, audience.
Thank you, Laura.